So I'll take the moderator's prerogative to say that I think what I heard as the most compelling organizing principle for all of our speakers this morning is this attempt to shrink the gap between what we know and what we do, right? So it's mostly seems to be about communication, knowledge management. It's not fundamental breakthroughs in science so much as it is effectively using that. And in that context, it's always appropriate at an Institute of Medicine meeting where there's been so much focus on a learning healthcare system. To note, I had a colleague observe recently that it appears we have the most intelligent group of slow learners in the world involved in healthcare. But the question I would like to ask each of our panelists is that, given, as Dr. Oluwole says, that the power is in the voice of the people. It's in the grassroots. It's in the understanding of the people who are the beneficiaries of screening, prevention, and treatment. Is what are the most effective and reusable lessons about educating at all levels, but particularly at the level of the populations who benefit, of doing cost-effective education for these classes of health problems we've heard talked about so eloquently this morning. And the panel is open. Anybody can take a shot at this one.
Well, since you mentioned my name, I could start first. Since you referred to me, I could start, and the colleagues would add on. I think some of the reusable lessons that we have found is the use of national champions to convey that message to the people at grassroots level. Some of the champions that have been extremely effective for us are first ladies of countries. In Africa, a first lady is regarded as the mother of the nation. And when she speaks, people listen. When she goes out there, people come out. Even though we did not talk about Tanzania today, but I'll give an example of Tanzania. We worked with Tanzania to organize a 2-day women's cervical cancer and breast cancer screening mass campaign in 2013. And we asked the First Lady to kindly lead the effort. She came out, and approximately 11,000 people turned out in one region. Men, women, girls, children. And within that 2-3 day period, over 3,800 women were screened for cervical cancer, and over 5,200 women screened for breast cancer. So we find their voice very compelling. Second would be members of parliament who go back to their constituencies. The third would be survivors, people who share their own story. And that reminds me of a lady. She's called Nurse May. She was one of the nurses screening patients in one of the clinics in Zambia. But she herself had never been screened. One day she decided, I have supported the screening of many women. Let me do the same for myself. She was found to have pre-invasive cancer, which could be treated with cryotherapy. Subsequent to that experience, she went out with the team, and she was able to talk to the women and say she herself had been through it, and they identified with her because she is one of them. They believed her. And also, her experience motivated others to come. And finally, women beneficiaries. In Zambia, people started to talk about cervical cancer screening in hair salons. You will hear people say, they just came to dress their hair, but they were talking about, oh, down the road, there is a clinic where women are being screened. Have you been? And this was how many people attended the screening clinic. So I'll stop here and give chance to others.
I just wanted to echo, I think survivors can play a really big role. But thinking back in terms of both the U.S. as well as the low and middle income countries, frontline providers may play a huge role, whether it's a community healthcare worker, and then clinicians themselves. They are what we're finding in the U.S., their recommendation to get vaccinated is really key. And so they're going to be ultimately getting the referrals, whether it's from the women or the community health care worker. So I think that would be important. Husbands can play a big role, especially in many of the low resource countries where males are an important group to facilitate screening, accept screening, condone, accept screening. And then the other point I wanted to just make about screening is that screening is a relatively new concept for low and middle income countries in terms of screening when you're asymptomatic. So that will require some education as well in terms of why would I get screened if I'm not currently sick. So that would be another important issue.
And the only thing I would add is just, especially in the communities along the Texas-Mexico border, just really the power of the promotoras and community healthcare workers. The women really want to hear from their peers that this is important. So I think there, as well as many places in the U.S. Just a quick story about the vaccine. I think the big thing with the HPV vaccine is that we marketed it all wrong, right? If from the beginning we had really pushed it as an anti-cancer vaccine, I think we would have had much higher acceptance and avoided a lot of the problems with it being associated with a sexually transmitted infection. We had a meeting at the CDC probably a year ago now, a bunch of us from MD Anderson, and one of the things that they talked a lot about was it would be great to have a cancer center really pushing the vaccine because they said people don't want to hear it from the government. We said, well, I don't know if they really want to hear it from us. And many times I talk about the Angelina Jolie and BRCA story. I do a lot of work with BRCA and trying to get women with ovarian cancer and their family members tested. And we have pretty good success, but when Angelina Jolie announced that she had a BRCA mutation, was having prophylactic surgery, our phones have been ringing off the hook even now because of that. So really, some good advocacy and public figures really pushing the HPV vaccine.
Great. I'm going to take a bit of a minority view on this point, which is that I think there's an enormous amount that can be done in terms of national leaders, in terms of physicians, and of course, frontline health workers. But I do think we need to keep in mind that this transition, at least in low and middle income countries, is happening in significantly poorer populations and much faster than it did here. And I think the expectation that the shift from acute to preventative and chronic care will occur with virtually no support from the international community, I think is unrealistic. And when you look at our response to other global health programs, we didn't wait for a patient movement around many of these areas before you saw an involvement of the US government, before you saw the involvement of multilateral actors. We acted, we demonstrated feasibility, we demonstrated cost effectiveness, we met them halfway. And we've seen some of that through the wonderful pilots we've heard described on Pink Ribbon, Blue Ribbon, and some of these other ones, but they're very limited in just a small number of countries. And the shift is happening now, and I think we really also, instead of just looking at what these populations and governments can do, what can we do to support them? And I think we can do a lot more.
Okay, well, thank you for that. And with an eye on the clock, what we'll do is open the mic for those. Wendy, did you have a question?
Wendy DeMar, University of Alabama at Birmingham. Great start to the session, or a great start to the workshop. And I had a question for Dr. Aliwala regarding the HPV vaccine program and the reaching out to the kids that really weren't involved in the school district or in the school system at that time, because I think that does Those are the high-risk children for not only sexually transmitted diseases, but a whole host of other factors such as smoking and poor dietary habits and poor physical activity. And I was just wondering about more specifics about how you reached out to them.
Yes, in Botswana specifically, because they have a very good system of tracking patients who are on antiretrovirals, including children in the age group 9 to 13, what they did for the children that were not in school, which is a very small percentage, was to ensure that the infectious diseases centers that catered for these children's ARVs had HPV vaccine. So they delivered the vaccine to them when they came for their medication. But they also made sure that facilities within the districts where the HPV vaccination was being carried out were also supplied with HPV vaccine. So any girl who came in and did not have the vaccine in school would receive it at the facility. They gave them cards to go with, so everybody knew who was covered and who was not. And just a little addition to that, for the 2015 nationwide rollout, instead of 3 doses, they adopted a 2-dose strategy, and the 3rd dose was only provided to HIV positive girls. And they delivered this in those clinics that I'm talking about. Every time that the girl went in for her medication, she would get her 3rd dose. So it was that well organized. It's just a health system that works a little better than most other developing countries.
Thank you. Marcy?
Thank you. Lisa Stevens from the NCI Center for Global Health. Really 4 excellent talks. And I want to pull out, Doyen, you gave an anecdote in the context of your talk about trying to convince government leaders to spend additional funds, and the fact that we invest so much in childhood immunization or perhaps ARVs, and then women get to a certain age and they're going to succumb to cervical cancer. And if we go back to Tom's talk, he mentioned that of the US government global health spending of $8 billion, we're spending under $11 million for NCDs. And so I just wanted to start the conversation about what's the argument that we use to adjust this overall spending for ourselves? And again, back to Doyen's point, how do you really convince governments to set this as a priority for their spending?
Sure. So as part of this outreach around this task force report I mentioned, we met with all the relevant U.S. executive branch agencies. We met with 40 different offices, Senate, in the Senate and the House. We testified. I testified before the Senate on this issue, and what you hear from a lot of policymakers on the legislative side is, we've never heard about this. When we have all our meetings on global health, they focus on communicable diseases. Why is this the first we hear about it? And when you speak to the executive branch agency side, what you typically hear is we're restrained by our mandates from Congress. And I think both are true. I do think, and having been on the executive branch agency side, it can be difficult to do this, but I do think fundamentally it is the role of the agencies to push Congress a little bit on these issues more than we're doing now. I do think it's also the role of the community to do this, but I think one of the things that surprise people around this report, in my view, is that how young these populations are, the fact that it's really the same population. We are spending billions to address one set of preventable, treatable diseases and watching them succumb to another set of preventable, treatable diseases seems like poor economic stewardship. And I think as a community, we need to do a better job of asking for it. But I think there's a acceptance, by and large, for people that work on NCDs that there will never be funding for this. So we should talk about how do we do domestic mobilization and blended finance. And in my view, I don't think we should accept that. There may not be HIV level funding. There's really HIV level funding for nothing other than HIV. But I think there's a lot that can be done, particularly if you look at how existing platforms and the populations are addressing on. A lot of people for a long time thought maternal health was hopeless. There was no money for maternal health, and this was a area which lagged far behind spending on other areas. And what you've seen is really in the last 7 years a significant increase. And when you talk to people about how that happened on maternal health, it's happened because there is an understanding that you cannot spend money on newborn and child health and not care about mothers. And I think one thing that we need to get across about the way we approach global health is this is fundamentally about those countries and those populations. And we should care about what the burden is from that perspective. And again, if we care about them for these other conditions, it's really hard to understand why we don't care about them for these.
Excellent. And Greta gets the last question.
Great. I'm lucky. So mine is really kind of a follow-up to that question and answer. So I think you made an interesting point that global funding does not really related to diseases that are a threat to the United States. But a lot of times the case is made for HIV funding that high prevalence rates of HIV undermine the infrastructure in foreign countries that could lead to kind of security concerns. So I'd like to hear you, is that the reality, or is that just a case that's made that kind of helps the funding move along? And is there something to be learned from that argument that could be transferred to cancer prevention or non-communicable diseases more broadly?
On the national security, there have been a number of studies not done by me looking after the fact at the national security arguments around in support of increased engagement on HIV. And it's a bit of common sense, but I mean, when you see the varying rates of prevalence in countries, there's nothing around the political instabilities or armies invading them that you can associate with those varying rates of prevalence. It's really hard in the aftermath to say this was a hard national security argument the way it was made out to be at the time. That said, I do think there's something to be learned from HIV in that context, in that it really drew on pilots. There were pilots that people pointed at how this would look. They were shovel-ready interventions, and we talked about, again, countries and populations we cared about and the scope of this problem. I don't think we need to figure out how to make NCDs a national security threat, that countries will collapse if their cervical cancer burden hits a certain level. But we do need to make it clear, again, that if we care about these countries and populations, it's really hard to understand why we would not care about something that represents a much larger burden at a much younger age than what I think a lot of people assume.
Great, thank you.
On the panel, wish to supplement those elegant words? All right, so
Can
go
I
ahead.
just add something?
Go ahead.
Thank you for your comments, Tom. I just wanted to comment a little bit about donor funding. And I think that the U.S. government or somebody does need to step up, because donor funding is quite limited in terms of where they're focusing their work for cancer prevention control. While they're doing a wonderful support of some surveillance systems, cervical cancer screening and treatment, I think it's quite limited in terms of their large infrastructure for a variety of other activities. So it does need to come from another player.
So I'd like to thank all of our speakers for a wonderful kickoff session and ask for a round of applause for them. We now have a 10-minute break, if there ever has been such a thing at the National Academies, and we'll reconvene at 10:40.